Good afternoon and welcome everyone to our monthly Geri Echo webinar. My name is Sarah Tompkison and I'm a social worker on the Echo Hub team. I'd like to give a thanks to our sponsors for this event, which is the Queen's Medical Center and the University of Hawaii John A. Burns School of Medicine, Department of Geriatric Medicine. Please join me in welcoming also our interdisciplinary Geri Echo team, which includes Courtney Nunukawa, our pharmacist Reese Bueno, and our physical therapist Chris Bell, and geriatrician Rita Bell Fernandez. As a reminder, evaluations are required for CMEs, and you can find the evaluations by following the link in the chat or at any time on our website and email advertisement. We are currently offering CME for physicians, DOs, RNs, APRNs, and physician assistants. I have even better news that you can download now your CME certificates anytime by simply going to the Queen's Medical Center's website at www.queens.org, and then you can click on your CME transcript. If you have questions about your CME, please refer them to cme@queens.org on the slide. Your comments are very important to us, and they're very useful to our planning committee for future programs. We want to emphasize that this Echo webinar serves as a forum for mutual teaching and learning from experts and from each other on the front lines. As the Echo motto goes, all teach, all learn. And in the spirit of aloha, we ask for that you turn on your cameras to help us build a community of learning. And please feel free to eat your lunch during the session as a way to take care of your health and provide good nutrition. Today's webinar consists of a short lecture from our presenter that is followed by comments from the expertise of our Echo Hub team. And of course, you, the participants' comments, your questions, your case examples for discussion. We want to invite you to share any geriatric cases, but we ask that you please keep them HIPAA compliant. This includes not sharing the patient's name, birth date, address, and so on. We learn best from our patients and our clients. They truly are our best teachers. On behalf of the whole Hub team, I want to thank you for your attendance, your participation, sharing of collective wisdom on the with Geriatric Echo. Due to Geriatric Workforce Enhancement Program grant funding cuts, unfortunately, today will be the last Echo clinic for 2025. We thank you for helping to build a strong community of lifelong learners, and mahalo again for your commitment to improve care for kupuna in all of our islands. It's a great pleasure for me to introduce Dr. Kore Liow, who's our speaker today. Dr. Liow is the founder of the Hawaii Pacific Neuroscience and clinical professor of neurology at the University of Hawaii John Burns School of Medicine. Did you know that his team has served more than 20,000 patients from all Hawaiian Islands and making a global impact with more than 40 clinical research projects that he's undertaken, and the over 50, and Dr. Liow, you'll have to update us. You probably have more than 50 residents, medical, and research students on rotation. Of note, Dr. Liow is the director and principal investigator for the Alzheimer's Research Unit Memory Disorder Center. He was actually part of the groundbreaking research that was approved by the Federal Drug Administration back in 2023. They had approved a medication called Leqembi. It is so timely that we have him here as our guest speaker to provide updates on understanding next generation of Alzheimer's therapies. How are they different? So without further ado, welcome, Dr. Liow.
Thank you. Mahalo, mahalo, Sarah. Hopefully you can hear me okay. And aloha, everyone. And thank you for the privilege and honor of presenting for you. And hopefully my video is coming through okay as well. I can't see myself, but as long as you can see me, that's okay. It's my privilege and honor. I totally agree with Sarah that our patients are our best teachers, and that is so true. And after taking care of memory and Alzheimer's patients for the last 30 years, I totally agree with that saying. And John, could we just go to the title page and then maybe the objective, if you could? I think John is in control of my slides. And so I have a very simple task today, just to talk to you about the next generation of Alzheimer's therapies. That's great news. We now have at least 2 approved, lecanemab, lecanemab, and donanemab, Kisunla, which is great news for us. We have been involved in the trial of lecanemab since 2017, and was part of the contributed data to the approval of lecanemab. As a matter of fact, there was out of 1,782 patients submitted to FDA for approval. There were 1 Native Hawaiian and Pacific Islander that was our patient from Hawaii, which we're very proud to contribute the data. Are you seeing the slides okay advancing, Sarah, or it's not advancing? John, can you help us with that? Advancing the slides?
It's not yet
Yeah.
advanced. We see all the slide deck, but it's not advancing to
Oh,
the
hold on. Sorry.
Yeah, so yeah, thank you. There we are. There we are. Great, thank you. Thank you everyone for your patience.
There we go. We see it now, the objectives.
Excellent. Yeah, so we're gonna just give you some background on lecanemab, donanemab, and the great news is last year donanemab Kisunla was also approved. And we're going to talk about some patients that may be suitable, and also what I really feel it's important is also to give our patients option to talk about what are some of the emerging options that is coming up. So next slide. So these are all my research funding. I do a lot of them, like Sarah said. We have probably completed probably close to about 200 clinical trials by now, many of them in Alzheimer's. I also serve on the NIH review study section, review panel for grant. Thank you. Next slide. So the way that I explain to my patients this new treatments, basically we spend some time talking about the diagnosis, and then after that launching into treatments. Basically, I explain to them we have 2 different kind of treatments. One is symptomatic, which is donepezil, rivastigmine, galantamine, memantine, Namzaric, and what have you, and all some combinations of. They treat the symptoms. They don't slow the disease down, but also, we do have disease-modifying treatment that targets the biology in the hope to slow it down. We don't have a cure, so I don't tell my patients that we have a cure. We don't. But our hope is to at least slow it down. And the evidence are good. Treatments like lecanemab at least slow it by 22%. So next slide. And so let's dive a little bit into lecanemab and donanemab. So you can see that they both work on the amyloid cascade pathway, and which is the the end product is the little clump there, amyloid clumps, that we all know. So lecanemab blocks the pathway at the protofibril stage, basically stop it from going into the oligomers, to the protofibril, and then the protofibril into the soluble protofibril into the soluble fibrils. So that's where it blocks it. And the donanemab actually binds to the amyloid plaque at that stage. If you remember, back in those days in 2021, aducanumab was also approved, which is no longer in the market. Aducanumab blocks it at the second phase of the aggregation. So they are basically very similar. They are both what we call monoclonal antibody. The difference obviously is lecanemab is given every other week. Donanemab is once a month. I believe the efficacy are somewhat comparable. They both do have the risk of the ARIA, amyloid-related imaging abnormalities. Next slide, John. So obviously there are two challenges. Basically, challenge number one is most people always will, okay, that's great. That's now that FDA has approved two therapies. What do I have to worry about? Obviously, it's the amyloid-related imaging abnormalities. The way that I explain to my patients is what happens is we have to give our patients a lot of monoclonal antibody in the systemic system, or a little bit of it to get into the brain because of the blood-brain barrier. When we give so much of medicine, so in the case of lecanemab, we give 15 milligrams per kilogram, it really weakens the blood vessels, cerebral blood vessels. That leads to leakage, edema. So ARIA, you have two kinds, ARIA E for edema, which is actually more common, or ARIA H, hemorrhage, or microhemorrhage, or localized superficial siderosis. And we think ARIA because of increased cerebral vascular permeability as a consequences of the monoclonal antibody binding to the deposited beta amyloid. So on the MRI, you could see A image as just edema, and on the B image, edema on the south side, and on the C image, you can see superficial siderosis or microhemorrhage in the occipital, parietal occipital region. So this is something that I do discuss with my patients. And so the question is, what do you tell the patients? How common it is, and what are the risks? Who is at most risk? So next slide. So the way that I explain it is the risk is really dependent on the ApoE4 allele. So for example, in the case of lecanemab, if you're E4 positive, your incidence go from 8% as opposed to E4 negative, 8% of edema to 14%. And an incidence of hemorrhage goes from 4% to 13%. So it almost kind of triple your risk if you're positive for E4. In the case of donanemab, if you're E4 negative, your risk is about 11% for edema. But if you're E4 homozygote, you are 44%, almost 1 in 2, going to get edema. And I always explain that to the patient. Just because it's FDA approved, it's not risk-free. So there's that risk, and we always check the ApoE4 allele, and before we start anybody on the monoclonal antibody. So the next question is, patients would ask you, what kind of symptoms will I have? The most common symptoms with lecanemab and aducanumab and donanemab is headache and dizziness. Either they develop headache and dizziness are the two most common symptoms to watch out for. However, 90% of patients are actually asymptomatic. Keep that in mind. Most of the patients will not be symptomatic. So you have to, that's why after the 5th infusion, after 5th, 7th infusion, we actually do another MRI. That's going to change because now the doses are beginning to change as well. So it's kind of like we actually monitor the MRI. I would say that out of the people, that's pretty much correct. Out of perhaps 100% out of 10 patients that had ARIA, maybe only about 2 or 3 actually were symptomatic in my experience, in all my patients with ARIA. Okay, so most the dose, and also the risk gets higher when you ramp up the dose. That's why there's a slow titration. The dose, you start at a slow dose before it goes up to 15 milligrams per kilogram. Higher dose, the dose, E4 risk, and most of them, 90% is symptomatic. If they're going to be symptomatic, it's going to be headache and dizziness. Next slide. So because of this, we are already working on the next generation of monoclonal antibody. So I'm really excited because this is a problem that we have been working on for years. Center like ours that have been doing research. I mean, it's great that we have an approved therapy. It's FDA approved, but patients really have to understand that just because it's FDA approved, it's not risk-free. The risk is still there, especially with E4, especially if your MRI shows that you already have significant small vessel white matter disease. These are the patients that's going to develop ARIA, and these are the patients that really keeps me up at night. So I'm really happy to say that we are already working on the next generation of monoclonal antibody. So what are they? So the next generation is trontinemab, which is kind of cousin of lecanemab and donanemab. So to overcome the problem of getting the drug into the brain or going into the blood-brain barrier, they attach a molecule, what they call brain shuttle molecule. You think of a space shuttle taking people to space. This is a brain shuttle taking this monoclonal into the brain. So the brain shuttle transport the trontinemab into the brain. So on the bottom graph, you see that there's a red brain without the brain shuttle, just standard monoclonal antibody, and on the right side is the brain with the monoclonal antibody. With the brain shuttle, it just gets into the brain, gets transported. Next slide. Because of that, we don't need to give them that much of monoclonal antibody. So instead of getting 15 milligrams per kilogram, we are actually only giving them 1.8 milligrams per kilo or 3.6 milligrams per kilo. Is that great? We're just giving them a small amount of monoclonal antibody. The question, and obviously because we're giving such a small amount, there is no ARIA in the initial clinical trial, which is great. And that makes sense, because we're not dosing the body with a whole bunch of monoclonal antibody. There's no ARIA. The other thing to take note of is the efficacy and the speed of which it clears the amyloid. So in the case of lecanemab and donanemab, it takes about 18 months for the amyloid level to clear to less than 90%. When we did the PET scan on the brain, it took them 18 months. Guess how long did it take for trontinemab to clear the amyloid to less than 90%? Take a guess. It took them 3 months, to clear it. So not only did it safer, no ARIA, it clears the amyloid off more rapid, 3 months instead of 18 months. So these are the things that I'm really excited about. And we're going to start the clinical trial for trontinemab later this year. And we would welcome patients who are at high risk for ARIA, obviously keeping in mind that clinical trials we do not promise you treatment. You could be on a treatment or placebo. There's a 50-50 placebo or treatment. But however, if you're at high risk for ARIA, I believe, instead of having an ARIA, having a placebo is probably better than having ARIA, bleeding in the brain. So, okay, next slide. So here it is, looking at the graph. It took donanemab and lecanemab 18 months to get the amyloid level down to less than 90%. It took trontinemab only about 3 months, rapid clearance. Next slide. So that's challenge number one with the current approved treatment is obviously the side effects. Besides the side effects, it's also access. Who has time to come into the eye infusion center every other week? The good news is even lecanemab is coming up with a sub-Q solution, which has to be given, I believe, every 10 days. That's approved, FDA approved recently, but you have to start the IV form first. You can only switch to the sub-Q only after 18 months. And we have patients almost there that we're going to switch to sub-Q, which is actually great. However, we have also been studying, investigating sub-Q form for the last 3 to 4 years on another drug. But looks like lecanemab is coming up with a solution. So I think that's a great solution. So besides the ARIA, the side effect, the convenience, the access, converting it to sub-Q. Obviously, once a month, it's much better. And especially for our neighbor island patients, it's so important because they can't afford to come to Oahu every other week for IV infusion. So I do have a number of neighbor island patients that are actually already on the sub-Q monoclonal antibody for the last 3 to 4 years that we're investigating on that are doing really well. So we're really very fortunate to have some of this option. The second challenge that we actually come against is, are we really targeting the right target to stop the progression of Alzheimer's? So monoclonal antibodies works great on the amyloid. What about the tau? So we know the amyloid is outside, extraneural, outside. But the tau is intraneural, the skeleton, the microfibrils. What about those? So the question is, do we really have the right target? So what about inflammation? What about neuroplasticity? What about neuroprotection? What about bioenergetics, metabolism? So let me dive into at least one or two of them. Many of you may have heard about, the diabetic drug being tested in Alzheimer's. So I'll just touch base on that a little bit. Next slide, John. So someone actually asked, how did they even think that diabetic drug could benefit Alzheimer's patient? Well, if you look at the PET scan of Alzheimer's patient and diabetic patients, they are very similar. They have abnormal metabolism in the brain, both the glucose metabolism and also diabetic patients have twofold increase of getting Alzheimer's, and almost 70% of diabetics eventually develop Alzheimer's. So could that be a common pathway? We know that diabetic patients have cognitive decline, they have high incidence of neurodegeneration. So because of that, we have actually launched into the study using GLP-1R, glucagon-like peptide receptor agonist. Most of you know that as Ozempic, the injectable form. We have actually put some of our patients on Ozempic, but this is a pill form, 14 milligrams, 7 milligrams, and placebo. We have about a dozen patients in Hawaii that have been on this. We have been studying them for the last 4 years. Next slide. So is it working? So we know that, so it seems like, so there's close to about 20,000 patients now that are on either Ozempic or placebo, for the last 5 years. Our patients have been on it for as long as 3 years. So you can see on the graph that patients on GLP-1, they tend to go from the MCI stage into Alzheimer's less. The first 2 years, there's not much difference. But after about 2.5 years, patients that have been treated with GLP-1, they tend to be less likely to develop dementia. And it's especially pronounced after about 4 or 5 years. Keep in mind, they still eventually develop dementia, but it's just less likely. So there seems to be good data that it slows it down. Some of my patients have finished their clinical trial after 2.5 years, and actually asked me to prescribe the Ozempic. Obviously, I try my best, but obviously the insurance company, the payers are not covering it. So we're thinking of ways to try to cover this patient. Some of them just do not want to have IV infusion. They do not want to like the risk of ARIA, the bleeding and swelling the brain, and they like taking a diabetic drug. They have weight. What are the side effects? Most patients actually do quite well. The main side effects are weight loss. I did have one patient, older Japanese male who weight came down to about 90 pounds, but we actually lowered the dose from 14 milligrams to 7. His weight seems to pick up again, and he's doing really well on that. So this is another emerging therapies, working through the metabolic pathway, bioenergetic pathway for our patients, which I am really excited about, and I'm keeping an eye out for when things could actually develop and when FDA might actually approve the drug. So who knows? Next slide. What about other options? So one of the challenge with in the Alzheimer's treatment is, there's really very little options for patients who are in a moderate stage. Most of the clinical trials, most of the treatments, disease-modifying treatments are for patients who are early stage. Your MMSE has to be 22 and above for lecanemab. Even for Frontier study, the brain shuttle study, have MMSE has to be 20. What about patients whose MMS is 18, 16, 15? What do we do? And the reason that we don't think monoclonal might help is because there's amyloid is already there, already interfering the signal transmission, the synaptic function, So thankfully, there are really smart people that's working on this problem. So the people are thinking, well, why don't we just activate the garbage collector of the brain? The microglia of the brain is called a garbage collector. What if we just activate them and have them phagocytosis and autophagic and eat up all this amyloid? So there's another clinical trial called the TREM2 activated. It activates the microglia of the brain cells, which is kind of like the garbage collector. It goes and eat up all the amyloid in between the brain cells. So it's called the VHB 937. So this is also another monoclonal antibody. It's an IV infusion once a month. That we are going to start the clinical trial also later this year or early 2026. This is targeting patients who are a little bit later, hopefully to go and eat up all the amyloid. So this is obviously will not have the risk of ARIA. This particular treatment is also being tested in patients with ALS, and we will see how it works. And I'm excited to let you know that we will bring this treatment to our patients in Hawaii later this year and sometime next year. Thank you. Next slide. So what about patients who don't like IV? And some patients just say, that's great, Dr. Liao. You have lecanemab, you have donanemab, you have all this fancy IV brain shuttle. But you know what? I don't like any IV option. Do you have any oral options? That is not just symptomatic, that could actually be potentially disease modifying. Well, thank goodness we actually do. So we have actually been studying a compound called butanetap that blocks the production of translation of tau and amyloid at the very upstream, at the very early stream. When we look at the molecule of tau, amyloid, even prime protein, alpha-synuclein, there's a common homology at the 5' untranscribed region of the messenger mRNA. So we're stopping the translation of these bad proteins, toxic protein, very upstream, very early. So we have been doing this clinical trial since 2017. So we have about a dozen patients on Alzheimer's that is currently on this drug. Next slide, please. So we have actually published the results in 2022 in Journal of Prevention in Alzheimer's Disease on butanetap, which is a novel translational inhibitor, meaning that it translates the reading of the messenger mRNA into the tau protein and into the amyloid protein. It actually tested both in the Alzheimer's and Parkinson's patients. So obviously, the trial is going really well so far. It seems to slow the cognitive decline. But more important than just slowing the cognitive decline is we're actually measuring the neuro biomarkers in the spinal fluid of our patients. We see decrease in the T-tau, P-tau, beta amyloid, neuroglandin, neurofilaments, and TREM2, complement C3 of our patients. So I know that it's a lot of mumbo jumbo, but these are the initial clinical trials that we did with our patients right here in Hawaii. So we do have at least half a dozen patients that is continuing on this trial. I'm very pleased to say that this trial is going really well. The phase 2 part of the trial, they are studying the phase 3 where they will actually ramp up and recruit more patients. And this will be available. We are already screening patients. I have about 40 patients that are scheduled to screen for the phase 3. So why do patients opt for this? Number one is it's oral option. It's a pill that you take, no IV, no injection. Number two, no ARIA. no bleeding and swelling in the brain. What are the side effects? The most common side effects are dizziness, 10%, 5% nausea, 5% headache. Those are the worst side effects. And I think most people are okay with that. Even when they develop that, they do go away. So this is, again, another option for our patients who do not like IV options, who want an oral option. What are the rate of placebo? Placebo is 50% placebo and 50% treatment. Next slide. Okay, more good news. Besides this new exciting emerging treatments, there are some great news. For the last 10 years, we have been doing spinal tap on our patients' CSF, looking for, obviously, amyloid in CSF. And I can tell you that most patients our patients are amazing. They don't complain, but I'll tell you that they prefer not to have a spinal tap. It is invasive. So the good news is in the recent AAIC, Alzheimer's Association International meeting in Toronto, Canada, I was there last 2 months ago. They issue a new clinical practice guideline, or CPG. Just came out. How many of you heard about the blood biomarker, the blood test? So first thing to understand is that this test do not just to put into context, this test do not in any way serve as a substitute for a clinical evaluation. This test should only be used as part of a full diagnostic workup in a specialized care setting, either in memory clinic or geriatric clinic. So that's number one. Number two is there is a lot of variability. This company has this test, this company has this. So there is significant variability. They are not interchangeable. I would say many or most of the commercially available blood-based marker do not meet the gold standard threshold. So what is the gold standard threshold? They have defined it. The test that has more than 90% sensitivity and more than 75% specificity can be used as a triaging test. Okay, that means if it's negative, you do not need a spinal tap or PET scan. But it's positive, you still do need a spinal tap or PET scan. So that's 90% sensitive and 75% specific. The second standard test that's been given, if the test is 90% sensitive and 90% specific, guess what? It is a substitute for PET scan and spinal tap. Isn't it great news? We don't have to have invasive procedure or expose ourselves to radioactive substance like PET scan in our brain. This is great news for our patients. This is less invasive, less costly, more accessible, especially for the neighbor island patients. We can't expect them to fly here for a spinal tap or fly here for a PET scan. It's expensive. They have to have their family, their honor come with that. So this is great news for our patients. And I'm really excited to let you know that. Next slide, John. That we are going to, because we are part of the brain shuttle test, we will offer free screening of p-tau 217, the Lexis system, for the Frontier, that has actually received the FDA breakthrough device designation last year. Positive results indicate high likelihood, of having, and negative results means that you don't need a spinal tap, you don't need a PET scan. This is a real world data that supports it as a standalone blood test, comparable to PET scan for rule in or rule out identification of amyloid pathology. And this is great news for our patients, that they don't need a spinal tap, they don't need a PET scan. But again, just not all tests are the same. So the tests offered by, the labs in Kona may not be this standard. So this is very specific to this particular test, and is only offered as a research at this point. And we can actually offer to anyone 50 to 90 years old in Hawaii for free. So you have to do a memory test, and then we'll offer this test to you for free. But you do need a follow-up with me, to go through the results, because we don't want somebody just to have a positive test and not have things explained to them, because there are implications. So again, John, if we could go back to the last slide, the previous slide. I want to, no, go back, the previous slide. Go back 2 slides. 1 slide forward. Thank you. 1 slide back. There we go. Again, this test do not serve as a substitute for clinical evaluation. Okay. Number 2 is not all blood tests are the same. I would say most tests, I'm not aware of any blood test in Hawaii right now that has this standard as what we can offer. Okay, the next slide. So the only blood test that I'm aware of that has this standard is the one that we can offer. So if anyone 50 to 90 years have memory concern, we can offer it to them for free. Okay. Thank you. Next slide. So what are the options for my patients in Hawaii? So obviously we do have lecanemab. We have many patients that are currently on lecanemab. We have done about 50 plus patients on monoclonal antibody, whether lecanemab, or other monoclonal antibody that's active here. And again, just because it's FDA approved doesn't mean it's risk-free. You know, we have patients that have ARIA, and luckily when ARIA happens, it's mild. It's observable, it's reversible, although they said you can continue, watch, when the ARIA goes away, you can continue the infusion. So far, none of my patients with ARIA wants to start the drug back. And I completely understand once you have bleeding and swelling in the brain, you're kind of hesitant to restart the drug. Luckily, most of them are mild. But I do have to say that I do have one patient who had a stroke, one patient who had a seizure. So just because it's FDA approved, it's not completely risk-free. And ARIA, although thankfully most of the time they're mild, but they can be serious. So I don't want to minimize that. So because of that, I also want to give my patients other options, you know, the options to be in the clinical trial for the next generation, the next new thing in monoclonal antibody, which is the trontinemab, the brain shuttle with no ARIA so far, and once a month infusion, you know, and also rapid clearance. It clears the amyloid in 3 months instead of waiting for 18 months for lecanemab and donanemab. And also patients on bioenergetics, also patients who are a little bit later on moderate, MMSE less than 22, they're not going to qualify for lecanemab, donanemab, or trontinemab, MMSE, but it has to be 18. We can offer them TREM2 microglial. It is also IV infusion once a month, where the microglial will eat up the amyloid. And lastly, for patients who don't want any IV infusion, we can offer butanetap, which is once a day oral option. You do have to be positive in your p-tau 217. And for anybody with memory loss concern 50 to 90 years old in Hawaii, we can offer you free screening with p-tau 217. So next slide. So with that, so what does the future look like? It looks great, you know, because a lot of people say, oh my gosh, there's only this option. I have to get IV, you know, I'm at risk of bleeding and swelling, and this is the best option. No, in 2024, there's 164 clinical trials testing 127 drugs. Thankfully, majority of 80% disease modifying drugs. 57,000 patients participate in clinical trials. And average drugs take 13 years to develop. And I'm so thankful that we have, you know, in last year, over 1,000 patients here in Hawaii participate in clinical trials, whether in Alzheimer's or other things, you know, and we have, out of the 127 drugs, we were able to offer 7 different drugs in Hawaii to our patients, you know, who otherwise would have to travel to the mainland. So with that, I want to thank our amazing team of Alzheimer's team at Hawaii Pacific Neuroscience. Next slide, John, thanks. And this is our wonderful doctors, neurologists at the Memory Disorder Center and Alzheimer's Research Unit at Hawaii Pacific Neuroscience, and our medical students who are doing research with us on Alzheimer's and other neurologic diseases. So this is our amazing team. Thank you. Without them, we couldn't do it. And thank you, mahalo to many of our patients who are willing to do the clinical trials only because of you. We have drugs like lecanemab, we have drugs like donanemab, and our goal is to make options available to our patients, especially the one on the neighbor island, so that we can let them have options, so they don't feel like lecanemab or donanemab is the only option. It is not the only option. Um, Okay, that's great. Thank you so much, Sarah and Dr. Fernandez and John, for giving me the opportunity to share, and what an honor to do your last echo for 2025.
Yeah, I think we're definitely going out with a bang in many ways. Thank you, Dr. Liao. There were a couple, before I ask the other Hub team members to give their comments and to ask questions from the audience, I just want to really commend you. I don't know how you keep track of your 200 clinical trials. But the thing that popped out for me when you talked about how the future looks for treatment options for people, were the fact that, people used to have no hope if they scored below, if they scored an MMSE below 20, they were considered not eligible, or they didn't meet the qualifying criteria to even be considered for some of these options. Like I think it was the trend to that. I love that visual image of the garbage collector. But the key thing is that not only does it give hope to people that might be not in the beginning stages of their Alzheimer's, but then again, you look at prevention, the intervention with the blood based markers. And that I just wanted to ask if that, being that it's part of your diagnostic workup for people that think maybe they have memory problems, or maybe their PCP might refer them, is this going to avail itself to folks on the neighbor islands with possible, I don't know if they have, and it's a trial, so they don't have to pay for insurance. I mean, they don't have to worry about insurance covering the.
Yeah, great question, Sarah. Thank you for asking that. I would say maybe about 10% of our patients actually from the neighbor island. We have our heart really goes out to them because it really have quite limited resources in terms of access, and even when they have it, it takes the entire day for them to fly here with their ohana, it's take time off. So our hearts really go out to them. So the great thing about being part of a clinical trial is everything is free to them. Number one, keeping in mind that we don't promise them treatment. It could be on treatment or placebo, number one. And the second thing is also many of our trials also pay for their travel and their companions' travel here, and the nice thing about it is when they're part of a clinical trial, we actually follow them very closely, kind of like concierge service. So we know the patients very well. I can think of at least one very highly educated. It's an ambassador who lives on the Big Island. Whose wife, they're very educated. They did not want lecanemab. They didn't want to fly here every other week, so they opt for the sub-Q option, one body, and they're doing very well. They just have to fly here once every 3 months for the injection. I have other patients on the neighbor island that fly here once every 3 months for a tau clinical trial where we actually do intrathecal. We actually do spinal tap, inject the tau anti-tau agent, which we call ASO, antisense anti-tau, once every 3 months. So they fly here 4 times a year for the treatment. So we do have options for our oral option. A lot of our outer island patients like it because the follow-up is only once every 3 months. They come, they fly to Oahu, and when they fly, we cover their travel too. So we try to think of creative ways to increase access and help our ohana on the neighbor island.
Thank you for doing that. I'm going to ask first if Courtney could share, any comments, any insights or questions you have for Dr. Liao.
you so much. This is really a lot of really good information. I have many questions, so I was trying to think which to start with, but I think my first question is how, like, in your clinical perspective, and maybe I don't know if you're kind of seeing them clinically or only in the research trial, but with the monoclonal antibodies and the 22% reduction, what kind of functional kind of impacts are you seeing and quality of life impacts are you seeing?
Yeah, thank you. That's a great question. Um, so our experience actually date back to 2017 when we put our first patient on lecanemab. It didn't have a name back then. I would say that so in the clinical trial they measured a factor called sum of boxes SB. And so we actually monitored their cognitive function very closely. Um, I would say that the patients who has been on it a long time, um, there's still deterioration, unfortunately. So the way that I explain it to my patients is it's not a cure. It's a slowdown by 22%. But even with the 22%, my patients, you can still see the deterioration. They would go from, a good conversation to now they are kind of like struggling to find words and struggling to go out. They're not comfortable going out by themselves anymore. That they kind of went from the MCI stage to the Alzheimer stage. And now that it's actually approved, once your MMSE drops below a certain point, that the insurance company will no longer approve the drug for you. So we actually have to retest them, and once they drop, well, what I'm trying to say is that it does slow down, but I think the results very consolation price at the best, and when it well, we need better treatment. That's what I'm trying to say. Yeah. So that's why we're doing what we're doing. So
Yeah,
and again, I'm very happy that there's FDA approved treatment, but we need to do better.
yeah, I think I think it's really interesting, like the GLP-1s and bringing in this like multi-factor approach. So I think it's very helpful or hopeful for the future. So thank you.
Having said that, I think the future, having being in this field for a number of years and doing clinical trials research in this, I think the future, is going to be kind of oncology, where they have when you have chemotherapy, you have a combination chemotherapy. So this is what I think we are going to be in the future. We're going to put patients on bioenergetic metabolism. We're going to put them on amyloid agent. We're going to put them on tau agent. We're going to put them on a synaptic plasticity and neuroprotective agent. In the future, I think that's the future, but we're not there yet. I hope that in the next 5 years, we'll get there and start doing that. Obviously, it's going to be a very complicated clinical trial. You got to bring multiple agents on, and which agent do you use, and what are the doses, what are the interaction, what are the side effects? So there's so many questions. We have a lot of work to do. The neurologists are not as smart as the oncologists, so we're a little bit behind the curveball.
I don't think so. I think you neurologists are way up there. Just as a reminder, everybody, Dr. Liao has put in the chat some helpful links to the Hawaii Pacific Neuroscience Center and some of the other projects, for specifically one on the free Alzheimer's pre-screening. Next, I'd like to ask Reese for his take on the presentation. You're, being the pharmacist and all these drugs, you probably understand better than me.
Oh no, I mean these are very new drugs, but I guess some of my questions were about patient selection. You mentioned that there's different risks with different medications and it's shared decision making, right? But what percentage of patients would you say pick you up on the offer to try, some of the newer medications or to enter a clinical trial, or even um uh yeah, or at what point do you introduce those alternative therapies versus the standard therapy options?
Yeah. Yeah, thank you. Thank you for the great question, by the way. So I think it's our obligation to offer patients approved therapy first and foremost. So how I do it is I often go over the diagnosis. This is what I think you have. This is your CSF positive, or your p-tau 217 is positive. This is what I think you have. And then I want to let you know that we do have an FDA approved therapy, lecanemab and donanemab. This is what's needed, IV once a month, and these are the risks of ARIA. The risk of ARIA really depends on your genetic profile. If you're E4 positive, your risk could be 40% for donanemab for ARIA, and you have to be okay with coming in here for infusion every other week for now. Most of them is like, what? I don't have time. I gotta go play golf. Who wants? I don't. I've done enough seeing you every 3 months, Dr. Liao. I don't want to see you every 2 weeks for infusion. Most of them express that. And so then I say, okay, I understand. And then we launch. Well, we do have other options. Keep in mind that these options are study options. We do not promise you treatment. You can be on the drug or placebo. There's other chances of placebo. Some are 50%, some are 25% placebo, 75% drug. I would say 50-50. A lot of patients do okay with lecanemab, donanemab. I would say the other 50%, they just don't want to do IV. They just don't want to come in every other week. They just say, give me an oral option. So we go to the betanetab oral option. Some of them, especially the neighbor island patients, they just can't fly here every other week IV infusion. And they're just not okay with the risk of ARIA. If they have ARIA on the Big Island of Hawaii, it tends to be a little bit more problematic. So they don't want that, so they opt for an oral option. They understand that there's a placebo, and we have patients on the oral options now since 2017 for the last 4 to 5 years that are doing really well. I have patients who swear that they are doing great improvement. Those are the patients that I really think they're on placebo. They swear that they're doing so well. They're okay, but you understand that you could be on placebo. They say yes, but my wife is doing so much better. I'm like, okay, yeah, they're probably on placebo. So there's just a lot of factors. So here's what I would do. Here's what I would do. Reason number one is talk about spend time making sure they understand the diagnosis, whether it's a spinal tap, a PET scan, or blood test, and keep in mind that not all blood tests are the same. You have to be more than 90% sensitive and more than 90% specific to replace a PET scan or replace CSF. If it's not replaceable. You still got to get the spinal tap or the PET scan. Number one, spend time explaining the diagnosis. Number two is go over the approved therapy with them. Make sure the risk of ARIA, explain the genetic risk, explain the access, the inconvenience, every other week, and then give them options. I do have other options if you want to listen. Some of them said, nope, don't want to listen. That's okay. But I think it's our obligations, our moral obligations to give patients choice, to give them options. I think it would be I think it would be very sad if patients had ARIA and find out that nobody talked to them about other options. Do you mean that there's other options out there without ARIA? There's a disease modifying therapy. I understand it's a research, but now that I have ARIA, I have stroke. Nobody talked to me about that, and I pray that it doesn't turn into a legal case. But I think it's our moral obligations to give patients options. Patients are smart. They can figure it out, and let them make the decision themselves. Does it make sense?
Yeah, it's called informed consent, I believe. And you're speaking to, when you talk about it's a moral obligation, I think you speak to your integrity and your ethical principle to uphold that, Dr.
I think
Liao.
so. I think so. Yeah, I think we should give patients the options.
Yes. I'd like to hear lastly from Chris and then Dr. Rita Bell, especially since as a physical therapist, you're always assessing people's functional status in all areas. So, oh, you got to unmute yourself, Chris.
I thank you, Dr. Liow, for this wonderful presentation. We definitely do see a lot of dementia patients in the geriatric population that we're treating. I am hopeful with all these new research on these new drugs that we can offer them some options. I do feel giving them that informed consent on what treatments are out there and what options they can, be hopeful in their diagnosis and to prolong, like decrease that decline in their function. We always are, as therapists, trying to figure out ways to help decline, like slow down that progress of their decline in function with their mobility, their cognition. So I'm hopeful with these trials that you're doing. Thank you.
It's our honor to do that. Sarah, unmute yourself, Sarah.
Here I am. Do any of the other attendees? Oh, Rita Bell, I forgot to ask. Do you have anything to comment on? And if not, Rita Bell, anybody from any of the participants on today's Echo have a question for Dr. Liow? This is your one opportunity. I would ask it. He's a very busy person.
I guess I have one more question about the screening. Is to meet kind of qualification for having cognitive decline, is it subjective, or does like a referring clinician have to do some type of validated screening tool to demonstrate the cognitive concerns?
Are you talking about the blood test, or are you talking about the
Yeah,
Frontier
blood test.
blood test? It's actually, the nice thing about the blood test is very non-specific. Just anybody with memory concern,
Okay.
and then when they come in, it's very non-specific. So I have neurologists here in the clinic that say, well, I know the memory concerns from the seizure, but they want to screen anyway. Can they come? And I say, hey, all they need is memory concern, so they just have to have memory concern, but they have to be at least 50 years old and younger than 90. So when they come in, we actually do a memory test. We don't do MMSE, we do IST, International Shopping List, ISL. And then we do the blood test, the p-tau 217. And then I will actually schedule to see them back, because I think it's our moral obligation to go over the blood test results with them. I just feel that's the right thing to do for our patients. I don't want patients to be, with a positive p-tau test out there and wondering, what does this mean? What are my options? We have an obligation to explain the test results to our patients. Yeah. Does it make sense?
Yeah, no, that's great.
I had one more question too, also, Dr. Liow. Do you have any statistics on how many people, the percentage of how many people actually decide to stop taking the lecanemab or the
Lecanemab.
Yeah,
yeah.
And what happened? I mean, I'm sure you have to.
Okay. I can tell you. We have of those who develop ARIA, even though lecanemab and donanemab make us say, oh, you can continue once it resolves, I can tell you that 100% of my patients do not want to continue. Because when you have bleeding and swelling the brain, it can happen again, and none of my patients wants to continue if they have ARIA. Of those who did not have ARIA, I would say about 20% of patients, after maybe 6 months of infusion, 9 months of infusion, we call that fatigue infusion, treatment fatigue. They just get tired of it, every other 2 weeks. They get sick of it. They just decided that I'm done. I'm done with this. Yeah. So about 20% of those who maybe a little bit more, 2 out of 10 discontinue treatment. Of those who had ARIA, 100% discontinue treatment.
I guess it's really a lifestyle adjustment, yeah, to commit to coming in.
Yes, it is, unfortunately.
Well, again, we want to thank you, Dr. Liao, for this very informative presentation about the updates and the recent drug trials that are being offered to people living with dementia, and just to give those people a sense of hope. And I want to thank everyone for being active participants for our Geri Echo this past year. Dr. Marita wanted to know, how long does the infusion take? Dr. Liao was one question.
Yeah,
Dr. Marita.
about an hour. About an hour.
But they probably have to sit in your office after the hour and wait to see if there's any kind of immediate side effects or something.
For the first infusion, we look for infusion reaction. We look for sometimes we even pre-medicate them for the first infusion, yes. But after that, an hour, and then they really want to leave after an hour, really. They don't really don't want to sit around. But we tell them to stay for about an hour, additional hour after the first infusion, because we watch them for a reaction. But on that, just about an hour.
Thank you. Again, thank you, everyone. And a special shout out to also Chris, Reese, Courtney. Lucas couldn't join us. Lucas, we're thinking of you. And then Rita Bell. Take care, everyone, and have a good week. Mahalo, Dr. Liao.
Welcome. Aloha.
Thank you. Bye.
Thank you.